All right. Welcome everyone to this Wednesday session of Ground Rounds. In particular, I welcome all of the rheumatology enthusiasts who come to hear our speaker, Dr. Robert Terkeltaub. Dr. Terkeltaub hails from McGill University, where he did his medical education and completed his residency and his rheumatology fellowship. We were fortunate for him to come to the La Jolla area where he did a postdoctoral fellowship in immunopathology first at Scripps, and then was recruited here to join the faculty. As faculty member, he also had responsibilities as rheumatology section chief and served as interim chief of the rheumatology division at UCSD, and I hope he's fully recovered from many of those responsibilities. Certainly, his career was hallmarked by his extreme dedication, teaching and education. Certainly, his activities range from training PhD candidates, designing the third-year student MSK block, and he served as training program director for over 19 years for rheumatology. His excellence in teaching was recognized, and he was the recipient of many teaching awards. His research, however, is really perhaps the golden star on his career. He's probably the foremost researcher on the planet in crystalline arthropathy. He has over 200 original papers and over 100 chapters with 25,000 citations and growing every year. He's so his research accomplishments have been highlighted by several named lectureships. He's also an ACR master, and he was one of the founders of GCAN, the Gout Hyperuricemia Crystal Associated Disease Network, where he was actually awarded the gold medal for his activities there. And this is an organization that now has its own journal listed in PubMed, and is the most global meeting on crystalline arthropathy universally. And he has since separated from the university, but hopefully not too far. And he has remained very active in the gout research world, still president of GCAN, and he has taken the opportunity to serve on several advisory boards. I don't want to take up any more of his time, and I'd like to invite Dr. Robert Terkeltaub to the podium. And hopefully we'll hear about groundbreaking news in gout. Dr. Terkeltaub.
Thank you, Mary, for the introduction. And it's great to be here always. And I just have a question for the group once I show my disclosures. Everybody knows what gout is, but do you just a show of hands? Do you feel that your management of gout here at UCSD is optimal or suboptimal? Optimal, show of hands. Okay. So there's nobody raising their hand. So hopefully after the lecture, you'll be thinking more about this. So basically, we've got a disease that's defined by hyperuricemia and crystal deposition, monosodium urate crystals in saturated extracellular fluids with distinct phenotypes of acute gout flare, famous in history as excruciatingly painful and not a nuisance, simply a nuisance, but also associated with substantial systemic inflammation. And then chronic polyarthritis, sometimes mixed in with acute episodic flares and connective tissue damage. Part of that and tophi mediate a lot of the connective tissue damage, and their aggregates of urate crystals with fibrosis and chronic inflammation and synovitis at various loci. and then renal disease, including not just kidney stones, but in the most severe gout patients, interstitial nephropathy. And one of the aspects of human evolution was that we lost the hepatic enzyme uricase, which degrades uric acid to much more soluble allantoin, and we're prone to hyperuricemia and gout for that reason. What we have is a perfect storm of gout and hyperuricemia globally, where there's over 50 million people who have documented gout, and in the United States. And gout prevalence continues to rise. It's now over 5% of adults, estimated between 12 and 15 million. And then in the VA, it's about twice as much proportionately. And we used to think of this as principally a male disease, and it still is predominantly a male disease, but gout now has a shrinking male to female ratio, affecting about 5% of elderly women in the United States. Asymptomatic hyperuricemia, very common. And our mean serum urate in the United States is 5.5, which is very close to the solubility limit of urate of 6.8 milligrams per deciliter. Gout flare hospital admissions have doubled over the last couple of decades. And so I think that everybody's on the inpatient service has seen gout admissions, polyarticular disease often admitted for inflammation and pain control, and a dramatic presentation sometimes with marked leukocytosis, fever, and the need to not only give systemic therapy, but also to aspirate numerous joints and for diagnosis as well as therapeutic steroid injection. And gout is much more complex than it was when I started my career here a while ago. And we have a patient profile that's dominated by genetic and ethnic factors, including the unusual demographics of the San Diego VA, with many Pacific Islanders and a majority minority population in our gout clinic here at the San Diego VA. We have a surge really in the American population of urate elevating and inflammation-mediated comorbidities, the metabolic six-pack, including obesity, metabolic syndrome, type 2 diabetes, and extending to hyperuricemia being one of those, hypertension, and then hyperlipidemia with CKD, coronary artery disease, heart failure, and then the complexity of treating all those conditions with drugs that include agents that raise the serum urate, such as thiazide and especially loop diuretics, and the drug interactions inherent in that situation. So we have a perfect storm, and we've got to deal with how to treat gout in an evidence-based way. And in prospective controlled clinical trials, when you titrate allopurinol and febuxostat in a VA population, and San Diego was one site, I ran that site, and we was a very rich recruiting site. If you reach the sort of the bare bones serum urate target of less than 6 milligrams per deciliter, you do better. And basically in the VA population nationwide, about 80% of the patients, if you titrate allopurinol to the maximum and titrate febuxostat to the maximum, 80% of people reach that serum urate target. It's higher in some other studies, up to 90%. If you sustain oral urate lowering therapy at target, you improve clinically meaningful outcomes. In the last decade, we've had the major use of advanced imaging with ultrasound and dual energy CT to assess these outcomes. And flares, of course, are a very significant outcome, but it takes about a year or two to get substantial improvements in flares. But if you get to target of less than 6, a few wonderful and beautiful things happen. First of all, your urate crystal burden in terms of crystal deposits, tophi, shrinks. The inflammatory flares and connective tissue damage are reduced. And so the outcomes eventually are really favorable. And so getting people to target is the challenge. And so the serum urate really should inform more of the urate lowering therapy decision-making. In gout guidelines, we look at the frequency of gout flares, and the guidelines are if you have more than 2 or more flares per year, it's time for urate lowering therapy. But a very important study came out in JAMA in 2024 that looked over a 10-year period at what the baseline serum urate was to launch the 10 years of observation, including people who were on treatment. And it became clear that if people have a serum urate of greater than 8, then there's a markedly increased risk over a decade of more flares and flares needing hospitalizations. And then that new crystal deposits are seen by dual energy CT if the serum urate remains above 6 milligrams per deciliter. So you really don't have disease modifying therapy until the serum urate drops to below 6, and really below 5 is where you start to see the crystals dissolving. But between 5 and 6, you don't see new crystals form in the studies. And when you get to a serum urate of under 2, there's accelerating debulking of the tissue urate crystal deposits and remission, but we use that target only for severe disease. So really the treat to target space, I mean, the thinking is that really you should, in an ideal universe, get many of the patients to less than 5 milligrams per deciliter, but less than 6 is actually pretty decent unless people have tophi. The other gout clinical headlines are numerous and game-changing. There's major healthcare disparities. There's unbelievable real-world failure of allopurinol and use and treat to target urate lowering therapy, including in this place, UCSD, the VA. We've surveyed it, when I was here, we surveyed it, and it was very disappointing how overall suboptimal the treatment was of gout, even in this institution. Very high baseline urate, predicting major gout clinical sequelae, as I've mentioned, a major headline. And then the fact that poor serum urate control and gout flares worsen cardiovascular disease has been a remarkable finding. And as a side story, colchicine is now FDA approved for secondary cardiac event prophylaxis, above the standard of care of aspirin and statins. There's a new treatment for allopurinol hypersensitivity syndrome that I'll talk about, and that we really need to pay attention to allopurinol hypersensitivity syndrome and ABCG2 urate transporter pharmacogenomics, as I'll talk about. And another major headline is that SGLT2 inhibitors are uricosuric, and they limit incident gout. And the use of SGLT2 inhibitors has exploded into multiple indications, and these agents are very useful for lowering urate. They're uricosuric, as I mentioned, and also for limiting gout flares because they're anti-inflammatory. And then we have an emerging class of new drugs. They're selective uricosurics that I'll talk about that inhibit URAT1, and that the gut and the intestinal microbiome are actually central in hyperuricemia. The gut has been really neglected as a major contributor to hyperuricemia, other than people thinking about nutritional sources of purines. And that there's a major improvement in the use of intravenous uricase for chronic gout by adding methotrexate therapy, so we can get most people with severe tophaceous gout through a course of therapy. So let's talk about these headlines. And the gout disparities are remarkable. They're more prevalent. There's more prevalent and worse gout in African Americans. And some of this aligns with hypertension, and some of this aligns with chronic kidney disease. It's both in men and in women, and the alignment's somewhat different. But basically, if you look at African American adults, here in this very solid black line, as opposed to white adults, and you look at what's happened on the trend line for gout, it's way higher in African Americans than in white patients. And compared to white ancestry gout patients, it's not only African Americans, but also the Asian population in this country have a huge shortfall in evidence-based gout care, and not just use of allopurinol. And then the non-adherence among African Americans, it's startling. It's way more frequent than in white patients. It's especially an issue in the South of the United States, and less access to primary care and disproportionate gout and emergency department and hospital visits are associated with these healthcare disparities, which is not surprising, and higher medical costs that are outlined in this in the graphs here that are referenced. So most gout is managed in primary care. We're talking about 90% plus easily. And there's a shortage of rheumatologists in the United States, but rheumatology gets to see the people that have more chronic severe disease and gets to manage those people. But most gout is managed in primary care. And there's a huge system failure. The 2018 primary care urate lowering therapy guidelines from the American College of Physicians did not recommend urate lowering therapy. They recommended treat to limit symptoms as opposed to disease modifying therapy. Hopefully, because of the new clinical trials that have been done, hopefully the guidelines will change. The mandate is to have these guidelines revisited every 5 years, but nothing happened in 2023 or 24. Hopefully, eventually primary care will have more optimal guidelines, and that will change the quality of management. But the Western world reality is that allopurinol is dirt cheap. We're talking about less than $100 per year. And that the first line of therapy is allopurinol. And that's what the FDA recommends. It's already a 60-year-old plus drug. It's non-selective and it can kill people. And so because it can kill people, you start low and you go slow with allopurinol. We'll talk about allopurinol hypersensitivity syndrome. But the FDA guidelines and the rheumatology guidelines to use allopurinol is first line and starting at no more than 100 milligrams per day, less so with stage 3B CKD. And the allopurinol urate lowering therapy market share in the United States is about 95%. Febuxostat is a much more selective non-purine drug that doesn't have the problem of this relatively prevalent severe hypersensitivity syndrome. However, it got mangled in terms of accumulating baggage by the CARE study, which was published in the New England Journal, which found a death signal, a cardiovascular death signal, even though there was no difference in cardiovascular events. When comparing allopurinol to febuxostat, febuxostat had the death signal, and the FDA said, well, sorry, you can't use febuxostat as first-line therapy. That particular study, CARES, was a terrible study. Most of the deaths occurred after the drug was stopped, and the study's results were not replicated in the FAST trial, which was a slightly different patient population in terms of eligibility and inclusion criteria, and was done in Europe and Asia. And so, the issue is that you need about 400 to 500 milligrams of allopurinol a day to get people to a serum urate of less than 6. And in primary care, very, very rarely is more than 300 milligrams a day used. And the average dose used is approximately 200 milligrams. And that's when it's used. And allopurinol is only used to treat about half the gout patients out there. And so, again, we're hamstrung with allopurinol. It's nice and cheap. So is febuxostat. It's less than $100 a year. Thank you, Mark Cuban. But basically, limiting allopurinol hypersensitivity syndrome is mission critical. It's not that rare. It's rare until somebody gets it. And it happens. It happens everywhere where I go and give this type of talk. And we're talking about up to 5 cases per 1,000 new users globally. In a Canadian general cohort study, it was stunning that there was an 11-fold relative risk with CKD and heart disease because of the poor oxypurinol metabolite clearance of allopurinol. And there was a 23-fold relative risk for older Asian descent females with heart disease versus non-Asian young men. And so the risk for allopurinol hypersensitivity syndrome is somewhat predictable, but only unfortunately partly predictable. We have HLA-B 5801, which is a molecule that has a peptide binding pocket for peptide antigens. And oxypurinol is a very small metabolite of allopurinol, and it can sneak into the corners of this binding pocket and lodge there and directly engage the HLA class 1 binding pocket. It does so for all the HLA class 1, but particularly so for HLA-B 5801. And a very unusual drug reaction ensues of direct immune activation with oligoclonal drug-specific CD8 positive T cells that expand. It bypasses the need for antigen processing cells and cellular antigen presenting cells and cellular antigen processing. And it's not limited to specific T cell receptor V beta repertoires. And the process becomes basically a cytokine storm of an allopurinol hypersensitivity with immune-mediated tissue injury and severe systemic immune-mediated illness with a 25% mortality rate. And the people who survive often are in hospital for months on end. Toxic epidermal necrolysis and Stevens-Johnson syndrome are only some of the manifestations. It includes vasculitis and major organ damage, particularly liver and kidneys. And then because people slough so much skin and get into burn units, co-infection is a huge risk in these very ill patients, and so many die because of this. And eosinophilia and drug reaction with eosinophilia and systemic symptoms is another part of the picture here. But the most feared phenotype is this toxic epidermal necrolysis and the Stevens-Johnson syndrome, which can cause blindness, not just mucosal, oral mucosal disease. Well, there's some good news. This is another game changer. Jackanibs, we love Jackanibs, I guess. Maybe not enough, but toxic epidermal necrolysis in a Nature paper that came out in late 2024 was shown to have a type 1 and type 2 interferon signature in the keratinocyte compartment. And there was a marked clinical response. I don't know why the slide is so blurry on this computer, but even though it's blurry, you can see the skin clearing on these two patients. You notice that the patient on the left is East Asian ancestry, and a dramatic response to Jackanib therapy in allopurinol hypersensitivity syndrome. So something to keep in mind. The problem is a lot of the people get transferred to the burn unit, and we don't really have a say in what their management is at that point. So the system failure is really an issue in the real world where we treat patients. And the benefits of starting allopurinol low and going slowly higher is that it limits allopurinol hypersensitivity syndrome. There's a dose dependence effect. And allopurinol, when you titrate it to the maximum, it works really well. The drawbacks are it takes a long time to get to the target urate low in the urate lowering therapy regimen. You need many encounters for the up titrations, many more than is easy to accomplish when it's hard to get to see your primary care. And the gout flare burden is high in the first year of therapy. And when people start on allopurinol and get a gout flare, 1 out of every 2 stop allopurinol because of the gout flare, because they think that we're making things worse. So you need more prolonged colchicine flare prophylaxis than is typically prescribed. And then often colchicine flare prophylaxis is not prescribed, particularly in primary care. And really you need to go at months, at least 3 months after the target achieved is what the most recent clinical trials support. And then many people are allopurinol resistant. There's a common transporter gene variant ABCG2 that affects the enterohepatic circulation of oxypurinol. And some people, we really in rheumatology clinics, we really beat them high with the dosing of allopurinol, and their serum urate just won't get to target. And we suspect that they're non-adherent, but like, they fill their prescriptions, et cetera. And this non-adherence of ABCG2 is part of the pharmacogenomics of ABCG2 that we have to consider when we take a look at the gout patient in our clinic. And so the real world data and the clinical trial emulation data really should be considered by agencies. I'm not sure what the hell's going to happen to the FDA, but I mean, these data need to be more considered. And then patients have doubts about allopurinol safety, allopurinol necessity, and then the overall medication burden. Often these patients are on 10 or 15 or 20 medications, particularly in the VA here. And so the real world allopurinol non-adherence is 50%, about 50%, which is really horrible. And in the real world, in primary care, only about a quarter of the patients achieve a serum urate of less than 6. And rheumatologists only somewhat better. In our protocolized gout clinic that I set up here, we got to 70% plus, which is pretty much the standard for having a protocol-driven clinic. The pharmacist ran it, and basically that's a model that you can do in large healthcare organizations if you have motivated enough people. The Buxtet should be used in far more gout patients. Mark Cuban and Cost Plus, and the fact that the drug is generic, it's now less than $100 per year, and getting people to 80 milligrams a day of febuxostat will get people to target about 70 to 80% of the time. And that in terms of the real world results, the febuxostat therapy odds ratio, getting people to target, is 11.4 to baseline. So, yeah.
Is there mechanismal toxicities reported or proposed for febuxostat?
Yeah, in terms of, there can be severe cutaneous reactions.
No, I mean the coronary.
Oh, that, no. ABCG2 does have some effects on endothelial cells, and it's thought that perhaps there's something, even like when you withdraw the febuxostat, perhaps there are some effects of ABCG2 is pretty widespread, but it's nothing that's like very plausible. People put some ideas out there. Yeah,
Whites, like, the reason I'm asking this is because, like, you pointed out, you say later is, now we know that the coronary plants have MSU crystals alongside blood. Is it?
yeah. Okay. I have a question for you. Have you remodeled your house ever?
No.
Anybody remodeled their house? Is that an inflammatory situation? So yeah, when you actually we see this with imaging. So when you actually lower the serum urate to target, you start remodeling the urate crystal deposits. They start coming off the cartilage surface. You have smaller crystals. There can be basically all this connective tissue remodeling promotes synovitis and promotes flares. And so this is indicative of a response to therapy, is unfortunately so. Yeah. Febuxostat. Yeah.
Because
Yeah, okay. So yeah, I know you're right. So basically there's a lot of calcium apatite, crystals in plaques. And then if you really look with a fine-tooth comb, you can see some urate crystals. But like most of the studies use dual energy CT, and there's terrible artifacts with that method. Like it looks like you're detecting urate crystals, but it's actually the apatite. So we don't think that we don't think that basically febuxostat triggers more cardiovascular death. because of something like that. The whole field of urate crystals and atherosclerotic plaques is pretty controversial. So time for a change, more febuxostat in gout patients. And then what else should we do? Hopefully the primary care guidelines will recommend treat to target, we hope. And then earlier switching to second line febuxostat, and then new drugs. We have a situation where we have really old drugs. We have allopurinol, which can kill people. We have febuxostat, which the FDA says can kill people. And then we have probenecid, which is pretty useless. It was designed to prolong antibiotic half-life in people with venereal disease. That's what it was actually designed to do, because it inhibits OAT1 and OAT3. And so it's a useless drug, and it's hardly used at all. And so we can aspire to protocolize gout clinics run by MD extenders, but the state of medicine these days makes that difficult. We can use more colchicine flare prophylaxis, and we can selectively target gouty inflammation and its links to comorbidities. And we can pay more attention to pharmacogenomics if we can afford to pay for pharmacogenomics. And then also we can pay attention to the gut microbiome. So let's talk about, the tangled web of gout and hyperuricemia and comorbidities. So basically, we've got a chessboard of gout and all of these comorbidities. And gout patients often have 4, 5, 7 comorbidities here, and it makes life very interesting if you want to treat them optimally. I think that if I leave you with one concept, it's that gout flare systemic inflammation is not benign. Paper in JAMA showed that if you have recent gout flare within the last 60 days, you have a doubling of the odds of myocardial infarction and stroke, and a 5-fold odds ratio of gout flare linked to fatal myocardial infarction or stroke. Fatal myocardial infarction or stroke. And so, and this is, JAMA is the primary care journal. So we hope that this changes the philosophy about how bad flares are. And then people underreport the flares like crazy. And basically the underreported flares, I don't know why the slides are so blurred on this PC, but often people have 6 flares per year and are reporting 1 flare per year. And then colchicine, we have a FDA approval for secondary cardioprotection at 0.5 milligrams per day. However, it's not globally cardioprotective depending on the patient population of the studies. And so there's very little colchicine use in the real world for secondary cardiac prevention right now. SGLT2 inhibitors are wonderful. I don't think anybody would be prescribing them for gout alone, as opposed to gout with any of these comorbidities. The SGLT2 inhibitors seem to really do great with so many of the comorbidities. They are uricose-uric, and they're more effective in lowering the serum urate when people don't have type 2 diabetes. Some of the glucose that's pouring out in the urine is somewhat uricose-uric. So you can expect that the serum urate goes down by about 1 milligram per deciliter if somebody has type 2 diabetes, and may go down by about 2 if they have heart failure. But they limit flares. They're anti-inflammatory and they limit flares. So something to consider, lots of net benefits. I think this is potentially a game changer. But again, gout seems to, on the problem list, gout is often number 5 or 6 in these patients. So I'm not sure that gout will be the trigger for adding the SGLT2 inhibitor. And then the GLP-1s seem to inhibit everything by about 20%. But the gouty inflammation is not the same as Alzheimer's and not the same as the inflammation in chronic kidney disease and so forth. And we really haven't had studies with the more advanced GLP-1 RAs. We love tirzepatide, but we were looking for more studies with the GLP-1s. I think what the bottom line is, if you have a lot of weight loss alone, even without GLP-1 RAs, you have a pretty good chance of getting people to target. And so the subsets of people on various of these drugs used for weight loss, including orlistat, is that if you have a lot of weight loss, you do better in terms of getting to target. And then the GLP-1 RA is also associated with more arthritis, about 10% more arthritis, although less pain in osteoarthritis, but we don't understand why there's an association of GLP-1 RA use with about 10% more arthritis. And gout, after all, is an arthritis. So tailoring gout pharmacotherapy to comorbidities in an ideal universe can improve the standard of care. So ABCG2 becomes a player. It's certainly something that people think about more in Asia. ABCG2 drives urate excretion by the kidney, but even more so in the gut. And defective transport ABCG2 variants will decrease urate transport into the gut and are associated with early onset antophaceous gout and with more urate that has to be handled by the kidneys and a higher risk of kidney stones. It's the ABCG2Q141K variant strongly linked to allopurinol drug resistance, and also ABCG2 transports a uremic toxin, indoxyl sulfate, and deficient ABCG2 decreases CKD survival rates in mice. So the ABCG2, the allele encoding this Q141K variant, a variant that increases the destruction in proteasomes of ABCG2, in about 4% in African Americans, 10% in white patients, 19% in Mexican, 15% in East India, 30% in Han Chinese, Japanese, about 50% with Filipino ancestry. And so in the gout patients, this is all comers. In gout patients, for example, in those with Filipino ancestry, the vast majority have ABCG2 Q141K. And so they're more allopurinol resistant, and they have issues with how they handle urate that promote hyperuricemia and tophaceous gout. And so we have a double whammy in terms of pharmacogenomic considerations for urate lowering therapy. The heat map for HLA-B5801 is on the left, and the red means the most heat, and we're looking at Southeast Asia. Japan actually is not the hot zone. Only about 1% of the patients have HLA-B5801, but in Han Chinese, up to 20%, between 8 and 20%, and in Korean and Thai and Filipino populations, about 8%. African Americans have more HLA-B5801. It varies depending on where their descent is in Africa, but it's up to 7%, which is a lot because HLA-B5801 is only 1% in white patients. And the ABCG2 Q141K heat map actually very similar, but also in those of Mexican ancestry. So we have a burgeoning pipeline, fortunately, of highly selective URAT1 inhibitor uricosuric drugs. This is a transporter that exchanges lactate and other monocarboxylates with urate in the proximal renal tubule. So URAT1 is a reabsorber on the luminal side of urate. And it's really easy to inhibit this, and the drug becomes like a clamshell if you inhibit the amino acids that bind to urate in the channel of URAT1. And the pipeline agents that are going to all the way to phase 3 trials include a drug called dotinurad that's approved in Japan, China, and AR-882, a drug developed in San Diego right now in phase 3 trials, and several other agents. And they're spectacularly effective in clinical trials, greater than 80% of people getting to a serum urate of less than 6 with very minimal drug titrations that are required. And what's unique about these drugs is you're peeing out so much urate in your urine that you're really reducing the urate stores. And they also get a lot of people to less than 5 and a lot of people to less than 4 milligrams per deciliter. So this is going to change the landscape of urate lowering therapy. There is a new xanthine oxidase inhibitor in development that has pretty good results as well. Tigelixostat gets about 80% of people to a serum urate target of 6 with minimal titration. So, these drugs are going to be branded and they'll be expensive, and the pharmacy benefit managers who rule the universe will have some say in what happens. But like you look at AR 882, it not only lowers the urate, but it starts to melt tophi when you look at dual energy CT in the right panel here. So this is the new reality here, and it's at least we have new agents coming. And some of the new agents are going to target the gut. And some of the existing things that we do target the gut. And the golden rules of human gut urate homeostasis are that the majority of urate elimination is renal normally in healthy humans. And decreased renal urate elimination is by far the major driver of hyperuricemia in most with gout. And decreased renal urate elimination increases the demands on extrarenal urate elimination, which is a gut process largely, a little bit in sweat, a little bit eliminated sweat, but it's mainly the gut. And about a third of the urate is normally eliminated in the gut, but if you are stressing the gut with diet and changes in purine metabolism, and if you have an unhealthy gut microbiome, then you're in potential issues with hyperuricemia. And gut urate elimination, the elimination by the gut of urate, increases in CKD, fortunately, but with a ceiling effect. And the decrease of gut urate elimination is common because ABCG2, which we've talked about, is the major importer of urate into the gut. And the Q141K mutant is so common, and that impairs gut urate elimination. And the gut ABCG2 loss promotes early onset gout and tophi and renal uric acid overload and increased risk of kidney stones. So basically, you've got gut urate transport being bidirectional. And then when you look at the role of the GI tract in urate homeostasis, a lot of the action is where there's circulating urate, and it's transported into the intestine, all the length of the intestine. And you've got lactobacilli that attack purines, and you've got anaerobic purine degrading bacteria that will actually degrade urate and multiple other purines that you feed to them. And then the problem is that the urate will diffuse back and be transported back to the gut. 90% of the urate that we put into the kidneys is reabsorbed, and a lot of the urate that's put into the gut is reabsorbed as well. So we really need these purine attacking bugs, as well as urate and purine degrading bugs, to maintain urate homeostasis. And the microbiome is a wonderful source of therapeutics because human beings lack uricase, for example, and that's a huge enzyme involved in urate homeostasis. Microbiome has about 9 million genes versus the 20,000 in humans, and can provide compensatory enzymes useful in a lot of diseases. And the gut microbiota outnumber the number of enterocytes, and the gut microbiome is mostly colonic, and it exists in a deeply anaerobic environment, but there are many gut obligate and facultative anaerobes that sense urate, that grow on urate and consume urate and many other purines. And these gut bacteria also can affect ABCG2 and actually increase the amount of ABCG2 so that more urate is imported in the gut to be eliminated. And then these organisms in the microbiome have salvage pathway enzymes to process purines. They can modulate xanthine oxidase, and there's a variety of species, but basically most of the action is in the large intestine with obligate and facultative anaerobic organisms. And there's been some really spectacular findings that came out in 2023 that showed that gut bacteria actually take uric acid and convert it back to xanthine with a different xanthine dehydrogenase than the one in human beings. and that there's a gene cluster that's unique to these urate degrading bacteria that can actually take urate and convert it to anti-inflammatory short chain fatty acids, including butyrate. And these gut bacteria in preclinical studies compensate for absence of uricase. And that when exposure studies are done in human beings, the human beings in large cohorts, there's one published and there's one that's going to be published shortly. That's a validation cohort. Antibiotic exposure with clindamycin as opposed to Bactrim. So antibiotics that target anaerobes increase the risk of developing gout in association studies. And basically the anaerobic lysis of urate and other purines is a totally unique metabolic pathway, and that's why these new publications are so high profile, and they complement the well-established pathway by which lactobacilli on the lower panel attack and consume purine nucleosides. And what's stunning about this is that human gut have these very high capacity anaerobes that consume urate, and they comprise about 15 to 20% of the bacteria in the normal human gut, and mainly in the Bacillota species. And that gout is associated with gut dysbiosis, and the Bacillota species are depleted in patients with gout. And also there's a depletion of butyrate producing bacteria, whereas there's an enrichment in Bacteroides and Bacteroidetes, which lack purine degrading strains. And so the gut dysbiosis is one of the associations of gout patients. And then something really exciting on top of this is that these gut purine degrading bacteria actually in fecal microbiota transplant studies are shown to promote a better outcome in atherogenesis in susceptible mice. And in the ApoE knockout mouse model, when you actually lack these anaerobic strains, there's increased plasma purines and uric acid. There's no differences in the usual suspects that promote atherosclerosis. And there's worsening atherosclerosis, whereas in the mice that get fecal microbiota transplantation after they've been cleaned out to be notobiotic, they have decreased atherosclerosis. So there's a very strong linkage between gout and hyperuricemia and atherosclerosis, and this becomes a really compelling story. So the translational questions are that probiotics, there's only two that are approved. They're approved for C. difficile. Probiotics are unbelievably popular, whereas allopurinol is pretty unpopular among patients. So probiotic market in the United States is about $17 billion. And then probiotics can lower serum urate by metabolizing purines and urate, and that the preclinical probiotic effects are robust. But most of the clinical trials have been done in China. There's over 4 dozen, and they've been using these safe strains of lactobacilli, which don't have as potent urate lowering activity. We think that the probiotic approach could be useful as a complementary approach in patients with severe chronic kidney disease who can't eliminate urate well in their kidneys. And in Japan, for example, there's already an approved yogurt food supplement with urate lowering strain of lactobacillus. And some of the yogurts that we get here probably have beneficial effects on our serum urate, but not that much. It's very difficult to develop probiotics and to deliver them through the harsh environment of the GI tract, and to make sure that that there's this new colonization is not resisted by the organisms that are there, but there's the promise for new therapies based on the gut and microbiome. So I thank you for your attention and welcome comments and questions.
you're at 4. Kidney.
You're at 1? Yeah, it's okay. It's okay.
Do we know?
Yeah, so glutenine is thought to be one of the molecules that actually import urate into the intestine, but it's mainly ABCG2. And then, well, actually taking it back, we're not sure what the major thing is that takes it back. And some of it's diffusion. Some of it's been shown to be diffusion, but yeah, some of it's thought to be diffusion. But like it's, the kidney has this weird system for handling urate. I mean, it filters all the urate that it sees from blood and then reabsorbs 90% of it. And the gut is probably pretty similar. You get all this urate pouring into the gut, and then you better have some purine degrading bacteria because a lot of it's going to go back into the circulation. And that's why the effects of these probiotics are and these organisms are so potent preclinically. It's really remarkable. You can make mice uricase deficient by inhibiting uricase or using uricase knockout mice, and then you see spectacular effects on the serum urate due to these anaerobic purine degrading bacteria and the anti-atherogenic effects, which are astounding.
So we have 3 online questions and 2 in the audience. First, Dr.
Sure. So thank you for that excellent talk. Just with regard to the probiotics, what are the sort of dynamics of microbiome modification? Is this a treatment that you take chronically forever, or is there a tipping point that occurs when it's sort of self-sustaining?
Yeah, well, we don't really know because there's only 2 approved and for C. difficile, and those are fecal microbiota transplantation, which is just not an acceptable approach for gout. Luckily, I mean, that's been actually shown. There's a Chinese study that showed that people didn't want it, and it didn't work very well. They might have had one intervention that they didn't want it anymore. Yeah, I mean, so there's my review with Dylan Dodd at Stanford, who's the microbiome expert, is published now. It's online in Arthritis and Rheumatology, and we touch on and provide references to all the challenges of getting probiotics into the deep into the colon. And actually making sure they colonize and making sure they're not destroyed along the way and so forth. And then these are not the generally regarded as safe strains. And so the regulatory aspects of that are going to be more challenging. But I mean, this was just discovered in 2023, this whole new area of urate homeostasis and hyperuricemia. So we can expect it'll take probably a decade. But we already are using probiotics, many of us, to lower our serum urate, but we may not be aware of that. I mean, yogurt, for example, has many lactobacilli that have purine attacking properties. And so also the epidemiologic studies show that those people in the population that have high low-fat dairy consumption have less prevalent gout, less incident gout over a long period of time. So we're already, saturating ourselves with probiotics that are out there, and the range of probiotic products is just startling.
So one of the online questions is, are particular dietary changes recommended to reduce purine?
Yes, the problem has been that people have prescribed a low purine diet for treating people with gout and have been very forceful about it for decades. And those diets fail in the real world. They're not very palatable. And they only can get the serum urate down by about like 1 milligram per deciliter. And so you have patient misery. And they abandon that type of dietary approach. Common sense diets are the best, and you want to keep your patients adherent. And if you get them to target on allopurinol or febuxostat, then they will have fewer swings of their serum urate when they go out to a steakhouse or, you know, or do other things that are maybe excessive in terms of their diet.
All right, take one from the audience and then.
It was good that, as you know, I have a conflict that, the GLP-1 thing, I just want some more information about that, so. I think I was in your paper a few months ago on semaglutide and osteoarthritis.
Yeah, there's less pain in the osteoarthritis population, but like there was a new paper in one of the Nature journals, and it looked at, you know, a ton of comorbidities, and arthritis in general came up. It was higher in users. Yeah.
Patients get overly active from being sedentary to just take up tennis or something, and with injuries and stuff. But having worked through hundreds of adverse event reports, I don't see any arthritis around.
Yeah, well, I mean, this was an association study with all the weaknesses of it. Do I believe it? No, there has to be validation of that, but I mean, it came up as a very unusual signal. It got a lot of press because all of a sudden there was something that GLP-1s increased that wasn't good. So it got some attention.
So, from the audience online, in patients with gout and difficult to control hypertension, what are your thoughts about low dose hydrochlorothiazide or thiazide 12.5 milligrams and impact on urate levels?
Well, I think the most important thing in patients with gout and hypertension is to control the hypertension, because hypertension in itself it promotes hyperuricemia, and then hypertension is, you know, way more lethality promoting and morbidity promoting than gout is, and gout itself is something that is along for the ride in terms of hypertension.
So this is a different type of question. Do you prefer non-steroidals or a tapered course of prednisone for acute gout?
Okay, so when I have seen patients with acute gout over many years at the VA here, especially, I didn't believe it at first. The Medrol dose pack, I didn't believe there was enough, but like really, it's really the first day or two of the steroids. If you have a really good dose, that it works incredibly well, and it's very useful for the patients with CKD if you're not worried about their diabetes getting worse. I just don't like using NSAIDs, and even short-term bursts of NSAIDs can be associated with more cardiovascular morbidity and then GI effects. So I don't love using NSAIDs. And then low doses of colchicine. Pretty hard to beat low-dose colchicine in clinical trials. People have tried and failed for gout. And low-dose colchicine, I was the PI of the AGREE trial, which was a very controversial trial, but it showed that people used to drown the patients in colchicine. It was called dose to diarrhea or dose till you diarrhea. And that, you know, 1.8 milligrams over an hour was as good as 4.8 milligrams over 6 hours, and works really well. And so I like to use that. And the nice thing about colchicine is you can combine it with the steroid, or you can combine it with the NSAID. I don't like combining NSAIDs and steroids together to treat.
Is it a most? That's it. Extra. Synergy.
Well, I mean, you get so the cytokine players in gout, you know, IL-1 beta for sure, but IL-8, IL-6, these are all pro-atherogenic and some TNF produced. And so the cytokine burst with this severe, even albeit localized inflammatory reaction, spills over to the circulation. And then we don't know, there's some training of innate immunity too that gets a lot of publicity. There's a group in Nijmegen, Nihai Matea and Leo Houston, who've shown that basically if you train macrophages to respond to urate crystals, then the next time they see the urate crystals, they're going to have a mount a bigger response. And so it's possible that the response to the urate crystals in the joint might train a greater response to the appetite crystals that are sitting in the plaque, or to the cholesterol crystals that are sitting in the plaque. The cholesterol crystals also are inflammatory. They you know, yeah. So that's a potent mix. So something like that is most likely, yeah.
Well, I think that's all we have time for. Please join me in thanking our speaker, Dr. Robert Terkeltaub.
You know, I never met you.
That's why.
I'm so pleased. I'm so pleased. Yeah.
Yeah.